Ready? I'm Bill Boro. I practice in Annapolis, Maryland, and I want to thank Charles for all his effort in putting together this conference for over the years. Immense amount of work, and it's a great thing that helps us get into other conferences as well, and makes us exercise and practice our use of the English language. My presentation today is about a case report of a patient. Intervention of Menorrahagia through chiropractic and spondylotherapy. I'm sure many of you have had patients come in, hey doc, you got to help me. I don't want surgery. What can you do for me? I've never had regular periods. I've been bleeding heavily for 2 weeks. My gynecologist says, deal with it. What can you do? So Dr. Del Bello, it's not just in Chile and Brazil that people don't know what chiropractors can do or how they can help them. But Menorrahagia, the common treatment is surgery. If it can't respond to the drugs or if there's a other cause such as fibroids. But why chiropractic? Well, the National Board of Chiropractic Examiners in their job analysis report said that menstrual disorders is the only female reproductive condition that chiropractors see more than rarely. 72% of patients with dysmenorrhea also have back pain. But how many of your patients have back pain, female patients have back pain, but don't tell you about their menstrual problems? That's a very common thing, especially if we don't ask. And this patient that I had came to me originally for back problems and didn't reveal until much later that there was a menstrual issue. So some of the common female problems are fibroids, benign tumors of the uterus that affect about 4 to 18% of the population of women. Endometriosis, the uterine lining becomes implanted outside the uterus. This can be a chiropractic problem. Endometriosis is reverse peristalsis of the fallopian tubes and the process of trying to remove the uterine lining. That's neurologically controlled. Chiropractic should be able to assist in that. Affects 10% of women, 25 to 35% of infertile women. Adenomyosis, where the endometrial tissue gets into the wall of the uterus. It affects 20% of women. But the more common problems are dysmenorrhea, cramps, and pain during menstruation. Again, neurologically controlled, muscle activity. And menorrhagia, heavy bleeding, 20% of women. A normal menstrual cycle, 21 to 35 days. I'm no expert in this. But 3 to 5 days of bleeding generally. Average blood loss, about 25 to 80 milliliters of blood. A normal tampon use during a menstrual period might be about 9 tampons, 25 to 80 milliliters of blood during that period of time. In menorrhagia, these are the number of tampons used in 2 days. 32 Super Plus tampons this woman went through, each holding about 12 to 15 grams, which is about 480 milliliters of blood in just 2 days for normal periods for her. So if you want to make a comparison, to the left is what might be the normal amount of blood in a normal period, and to the right rather, be what amount of blood you might have coming out of a woman during experiencing an episode of menorrhagia. So the standard symptoms of menorrhagia: blood loss of more than 80 milliliters, periods lasting longer than 7 days, and soaking in 1 or more sanitary products for every hour consecutively, several hours. Menorrhagia affects 10 million women. A third never discuss it with their doctor. And the prescriptions of medications or the final result, surgery of removing the uterus and cervix. So several different cervical options that can be applied. This woman was 37 years old. She was a veterinarian technician, so she had a lot of heavy lifting in her job. 5'4", 164 pounds, no children. History of severe pain in her left hip, headaches and asthma, and nonstop menstrual bleeding for 2 weeks when she came in this time. As I said, she had been a previous patient for a back problem, and this was her MRI presentation when she first showed up with the back issue that she had. So there's posterolateral disc protrusion with an annular tear at L4, disc protrusion at L5, S1, and pressing on L5 and S1 nerve roots. Since the age of 16, she had never had a normal period. Migraines also accompanied cramping every month. Typically, her cycles were 36 to 45 days, with bleeding lasting 7 days. On days 2 and 3 of her, quote, normal menstrual period, she would go through a super tampon every 1.5 hours. Again, calculating 80 milliliters of blood loss in the first 2 days. Went to her gynecologist. He suspected fibroids. Ultrasound was performed, no fibroids. Suspected hormonal disturbance. Checked the hormones, no problems with the hormones. He said, well, you know, it's not bad enough that we should remove your uterus at this point, and you don't really want to get on all the drugs, so just, you know, kind of live with it. I asked her, why did she come see me for this problem? And she said, well, you've helped me with my back, and my cramps have gotten less, you know, over the last year or so, so I figured, what the heck. So it was a busy day. I did a limited assessment, but tried to think, what can I do for this woman? It's got menstrual problems. So you do your normal exam and find, you know, some few chiropractic indicators. Positive Trendelenburg, positive sitting straight leg raise. As I said, she had history of back pain and not a regular maintenance patient, so she just comes in when she needs to, as she perceives it, and she had an indication of category 2. Treatment consisted of 3 treatments over 10 days. The first visit, I adjusted her category 2. Now, in category 2 block placement, I kind of leave the patient on the blocks a bit longer, using the first rib head as my indicator. When the pain and tenderness goes away from there, I then take the blocks out. And oftentimes the patient will be a little stiff, and I over the time said, oh, let's take a look at this standing posture. I would then analyze the patient standing using muscle testing and challenging the vertebra and adjusting the lumbar vertebra for ranges of motion positions that would create subluxation patterns. So also did a standing lumbar adjustment with range of motion and adjusted the femoral heads bilaterally. Also, I did spondylotherapy on the first and second visit. Spondylotherapy is you use these 2 instruments here. On the left, a plexor that you place over the vertebra. The 2 bottom pieces here and here rest on the transverse processes, and then you bang the vertebra. Hit the plexor with the pleximeter, and this is demonstrating at C7, although I did spondylotherapy at C7, L3, and L5. I told the patient to come back the next day or the day after. Didn't show up for a week, so I'm wondering what's going on. She comes back a week later and says that the bleeding had stopped by the next morning. On visit 2, I adjusted T3, 5, 7, and 9 for tubal levels and also the discs in between, and also repeated the spondylotherapy treatment. Visit 3, again, just adjusted what I found. Adjusted the lumbar spine, the discs and associated muscles, and I also found subluxations in the cranium and adjusted them according to Van Rump's protocol for an anterior pattern. Little diagram of what one would find in an anterior pattern cranium by Van Rump's protocol. Sphenoid and temporal bones are anterior superior, and the mandible is anterior inferior. And challenging the sphenoid to get an indication whether posterior and anterior sphenoid subluxation is present. And then the adjustment correction follows those arrows. Interview with a patient a year and a half later. She reports that her periods are more normal. She now has, they're mostly every 28 days. There's not very heavy bleeding like there used to be, and she has no cramping. So a little explanation about what spondylotherapy is, because probably most of you never heard of it, and I may be one of the few practitioners still practicing it. But spondylotherapy was developed in the early 1900s by Albert Abrams. And in his earlier work in 1910, he said that he had examined 50 women. And he first started out just palpating the spine. He was an MD, but he would palpate the spine and identify that at the lumbar spinuses, there would be a lot of pain in women who had menstrual issues. And so he would just press on those like trigger points and relieve the pain and relieve the menstrual problems for either the day or the entire period. Later he developed the spondylotherapy instruments and also used an electric concussor as well, which probably the new vibrocussors and things like that probably relate back to his early work. But he believed that visceral symptoms and visceral problems could be corrected through concussive forces on the vertebral spinous processes. Alva Gregory, a MD, DC, early back in the 30s, also used spondylotherapy in combination with adjustments. And he felt that together it was better than just concussion by itself. In his book, Spondylotherapy Simplified, he describes that stimulation of C7 causes generalized vasoconstriction, which is why I concussed at C7. Stimulation at L1 through L3 excites uterine contraction, overcomes uterine hemorrhage, overcomes atonic constipation, excites contraction of the liver, spleen, stomach, and intestines, and increases tone in the colon and intestines. So, in conclusion, there's very little research about the relationship between lumbar dysfunction and menstrual problems. More research certainly can be done in the chiropractic realm. There's little research demonstrating the use of spondylotherapy as a treatment protocol. In the 40s, Joe Jancy, I believe, is the president of National Chiropractic, wrote a book with a couple other chiropractors, and there was several chapters on spondylotherapy, so I assume it was part of the normal curriculum at that time for chiropractic students. Don't see it anymore. The chronicity of the patient's symptoms and the temporal relationship between the treatment and the response is kind of self-evident. You know, bleeding for 2 weeks straight, nonstop, next day gone. While there have been few studies reporting the use of conservative chiropractic or any other type of treatment in female problems, again, more studies should be used. Women should not need to be given the choice of surgery to deal with their menstrual issues, and perhaps further greater interdisciplinary study should be considered. Thank you. I'm Bill Boro. I practice in Annapolis, Maryland, and I want to thank Charles for all his effort in putting together this conference for over the years. Immense amount of work, and it's a great thing that helps us get the drugs, or if there's a other cause such as fibroids. But why chiropractic? Well, the National Board of Chiropractic Examiners in their job analysis report said that menstrual disorders is the only female reproductive. So Dr. Del Bello, it's not just in Chile and Brazil that people don't know what chiropractors can do or how they can help them. But Menorrahagia, the common treatment, is surgery. If it can't respond to get into other conferences as well, and makes us exercise and practice our use of the English language. My presentation today is about a case report of a patient, intervention of Menorrahagia through chiropractic and spondylotherapy. I'm sure many of you have had patients come in, hey doc, you got to help me. I don't want surgery. What can you do for me? I've never had regular periods. I've been bleeding heavily for 2 weeks. My gynecologist says, deal with it. What can you do?